Welcome to our channel, Mootechie. Today's topic, bacteriostatic and bactericidal agents. This is our starting point for a crucial distinction in antimicrobial therapy. Microbiology and pharmacology, bacteriostatic and bactericidal agents. What you will learn: precise definitions and mechanisms, clinical relevance and exam tips, high-yield examples and visuals, and key differences highlighted. We'll build a solid foundation for your exams and clinical understanding. The two graphs show the core difference. One plateaus growth, the other shows a steep drop in bacterial count. Definition: bacteriostatic agents. Point 1. Inhibit growth. This means the agent arrests bacterial growth and replication but does not directly kill the organism. Think of it as pushing pause on the bacteria's life cycle. Point 2. Immunity dependent. This action relies on the host's immune system, like phagocytes and antibodies, to finally clear the halted infection. Your body's defenses need to finish the job. Point 3. Reversible effect. If the drug is removed too early, bacterial growth can often resume. This is why completing a full course of certain antibiotics is still critical. Point 4. High MBC by MIC ratio. The minimum bactericidal concentration, or MBC, needed to kill is much higher than the minimum inhibitory concentration, or MIC, needed to simply inhibit. There's a big gap between stopping growth and causing death. The diagram titled Bacteriostatic Agents Mechanism of Action shows arrows pointing to processes like inhibited protein synthesis, inhibited folate synthesis, and inhibited DNA replication. This visually summarizes how these drugs work by blocking key bacterial functions. A line graph next to it compares cell count over time between a control group and a group treated with a bacteriostatic agent. The control line rises while the treated line flattens into a plateau, perfectly illustrating the inhibitory, non-lethal action. Mechanism, mode of action, bacteriostatic. The key targets are listed: tetracyclines, macrolides, sulfonamides. They target different points: 30S ribosome subunit, 50S ribosome subunit, and folate synthesis. The result for all is jammed or inhibited protein synthesis. Each class blocks a different step, but the final outcome is the same. The bacteria can't make the proteins, it needs to grow and multiply. Next, we see a growth kinetics chart. The vertical axis is log bacterial count and the horizontal axis is time in hours from 0 to 12. A control line climbs steadily, a drug-added line rises until about the 2-hour mark, then it hits a growth plateau and stays flat. This plateau shows the bacterial population remains constant but viable. The drugs are holding them in check, not eliminating them. The clinical implication reinforces this. The drug inhibits replication, static, rather than killing. The bacterial count stays flat. This approach absolutely requires a functional host immunity to ultimately clear the infection. In someone with a weak immune system, a bacteriostatic drug might not be enough. Pharmacology. Examples of bacteriostatic agents. First, tetracyclines like doxycycline, minicycline, and tetracycline. They are 30S ribosome inhibitors with a broad spectrum and don't target the cell wall. Then, sulfonamides, which inhibit folate synthesis. Examples are sulfamethoxazole and trimethoprim, often combined as TMP-SMX or cotrimoxazole. This combination creates a powerful synergistic sequential block on the folate pathway. Then macrolides like azithromycin, clarithromycin, and erythromycin. They inhibit the 50S ribosome and are great for treating atypical pneumonias. Oxazolidinones such as linezolid and tedizolid also target the 50S initiation complex. These are important reserve agents for tough bugs like MRSA and VRE. Finally, lincosamides, specifically clindamycin, another 50S inhibitor. It's frequently used for anaerobic infections like in aspiration pneumonia and for certain skin infections. Here's a handy exam tip. Remember the mnemonic, we are ecstatic about bacteriostatics. This stands for erythromycin, clindamycin, sulfonamides, trimethoprim, tetracyclines, and chloramphenicol. It's a high-yield list to recall for your tests. Definition: bactericidal agents. Point 1. Directly kill. These agents cause lethal damage, leading to cell death and a measurable reduction in colony-forming units, or CFU. They don't just pause the bacteria, they destroy them. Point 2. Severe infections. They are the preferred choice for life-threatening situations like endocarditis and meningitis, and in immunocompromised patients where the immune system can't assist. Point 3. Post-antibiotic effect. Even after drug levels in the body fall below the MIC, the suppression of bacterial growth may persist, giving an extra period of protection. Point 4. Low MBC by MIC ratio. The minimum bactericidal concentration, or MBC, needed to kill is very close to the minimum inhibitory concentration, or MIC, needed to simply inhibit. There's a big gap between stopping growth and causing death. The action here is clearly labeled lethal or cidal. Mechanism, mode of action, bactericidal. The key targets are beta-lactams, fluoroquinolones, and daptomycin. They attack cell wall synthesis, DNA replication, and the cell membrane. The end result for all these is cell lysis and death. Each class breaches a critical structural component, causing the bacterium to literally fall apart or lose its genetic instructions. The kill kinetics graph shows this dramatic effect. Again, the vertical axis is log bacterial count and the horizontal axis is time. The control line rises, the line for the cidal agent rises slightly and then plummets in a rapid CFU drop. This steep decline visually confirms the lethal, irreversible action. The clinical implication is clear. This is irreversible cell death. The drug directly kills bacteria, leading to that measurable drop in CFU. Because of this direct action, they are preferred for serious conditions like endocarditis, meningitis, and neutropenia. Pharmacology. Examples of bactericidal agents. Starting with beta-lactams, which are cell wall inhibitors. This family includes penicillins, cephalosporins, and carbapenems. They exhibit time-dependent killing and are generally safe in pregnancy. Next, aminoglycosides like gentamicin, tobramycin, and amikacin. They bind irreversibly to the 30S ribosome. They are potent but come with risks of nephrotoxicity and ototoxicity, and they work in a concentration-dependent manner. Then glycopeptides, specifically vancomycin, which blocks cell wall synthesis by binding to D-ALA. It's the gold standard for MRSA but can cause red man syndrome. We also have miscellaneous killers, daptomycin, which disrupts the cell membrane, and metronidazole, which causes DNA damage. They are vital for severe skin infections and anaerobic bugs. Finally, fluoroquinolones like ciprofloxacin, levofloxacin, they inhibit DNA gyrase and topoisomerase, halting DNA replication but carry risks like tendon damage. Remember this key concept. Bactericidal is equal to homicidal. They directly kill the bacteria. This is why they are preferred for meningitis, endocarditis, and neutropenia. This slide presents a direct comparison. On the left, under inhibitory action, bacteriostatic, its primary effect is to inhibit bacterial growth and replication without direct killing. The host requirement is an intact immune system to clear the infection via phagocytosis. For kinetics, the MBC is much greater than the MIC, meaning a high concentration is needed to kill. Therefore, its clinical use is for mild to moderate infections in immunocompetent patients. On the right, under killing action, bactericidal, its primary effect is to directly kill bacteria, reducing the total colony count. The host requirement is low, it can function independently, making it preferred in immunocompromised hosts. For kinetics, the MBC is roughly equal to the MIC. The lethal concentration is close to the inhibitory. Therefore, its clinical use is for severe infections like endocarditis, meningitis, and sepsis. This side-by-side view really crystallizes the practical differences you need to know. Thank you. We hope you enjoyed this quick review on antibiotics. Subscribe to join Mootechie for more high-yield medical content. Comment below if you have questions about this topic. For our next topic, check out our playlist.